Hello. Good evening, Dr. Anirudh.
Good evening, sir. Good evening. Am I audible, sir?
Yes, absolutely.
Okay, sir.
Dr. Soham, good evening.
Good evening, sir.
Hi. Oh, you both were colleagues in PGI, yeah? Both of you?
No, sir was my teacher. No, no.
He
He
was a
was my
teacher?
student.
Yeah,
Oh,
sir was my teacher.
When he just joined, I took his first round.
nice.
He
That's
must have
good.
remembered that.
Yeah.
Yes, sir, definitely.
So all you are coming on 4th, correct?
I'm
So
Yes, sir.
we are eagerly waiting for you people. Today, Dr. Trupti, Dr. Muhammad Hayat Bhatt is coming
okay. They're
on
coming
3rd.
already, means?
Today, nahi, after day tomorrow, 3rd.
All right, all right. Nice.
So they
So,
must be
I,
visiting the OPD. Tomorrow is our busy OPD, Thursday.
so tomorrow, actually, I saw the agenda. Okay, so I am the chairperson for the first topic.
Yes.
I will be most probably I'll be reaching late in the night on that day because I'll be exchanging with Dr. Sharmagusundar. I'll inform you at least a day before.
Okay, so you will not be able to chair that session.
Yeah. So I'll come to the second or third session.
Not
Shanmugasundar.
an issue. We will exchange with someone else.
Yeah, yeah.
Not an issue.
The funda is there is a thunderstorm which is predicted in Hyderabad on that day. So flight will get even further delayed is what we are thinking. Myself and Dr. Bipin Sethi are coming in the same flight.
Okay.
Yeah.
Dr. Bipin's session is actually in the evening that day. So
Is it?
no issue with that. But yours is the, I think, first one.
Correct, correct.
So
So I'll
not an
exchange.
issue. We'll exchange with someone else.
Sure, sure.
And Dr. Anirudh, you have multiple role to play. You know not that.
Ji, sir. Yes, sir.
Hi, Dr. Soumya. How are you?
Fine, sir. Good evening, sir.
Good
Good
evening.
evening, sir.
So what are your working hours there? You finished with your work? You're at home now?
No, sir. It ends at 8:30 on to.
Okay.
Yes.
So we'll start in around 5 to 7 minutes. Nayantara is also already joined.
Good evening, sir.
Good evening. So I think we're waiting for Sangeeta. She's from the first session.
Hi.
Hi, ma'am.
Hi. Good evening.
So many trophies. It's very, very pretty. Can you hear me?
Yeah, I can hear you. Yeah. Hi, sir.
Hello. Good evening, sir.
You're muted.
Okay. So waiting for Dr. Sangeeta to join. I think she's going to join in a minute and then we'll start the program.
Hi, good evening, everyone.
Hey, Vimal.
Good evening, sir.
Hi.
So, Dr. Nayanatara, you will put the presentation from your side, no?
Yes, sir. I'll share the screen from my end.
Okay. So I'll start. I'll just introduce everyone first.
Okay, sir.
Hi, Dr. Ajaz, how are you?
Hi, sir. I'm fine, sir. How are you, sir?
Good. Sundar, can you make me the host, Dr. Sundar?
Yeah, just a minute.
Yeah.
Santosh, I don't have this one. The
Okay.
host is some Magnacode Healthcare and Research.
Okay, that is Sendil, I guess. Can you just ask him?
I will inform.
Yeah. Dr. Sangeeta, have you joined? Okay.
So shall I share my screen and start and be ready till ma'am presents? Is that okay?
Yes, you can.
Okay. Yes, sir.
Hello. So let's start the program. So good evening, everyone. So we should not delay the people who have already joined the program. So why did we even come up with this program? This adolescent PCOS discussion followed by how to present in a conference. So the actual thing started when we hosted ESICON 2023. There were many questions that were raised by the faculty actually, and many of the delegates is how you are able to get certain speakers to speak on time. How are they finishing on time? How is the discussion going on so well? So all those things were being discussed over there. So what we decided is, as a group of growing endocrinologists, Magna Centers for Obesity, Diabetes, Endocrinology, we have an education trust and an education foundation. Through that, we will take certain interesting topics that are going to be covered besides the routine things that we keep discussing about DPP4 and GLP-1 and SGLT2 inhibitors. We thought we'll go a little bit offbeat and we'll discuss certain things which will be useful not only for our endocrinology careers, but also to be better doctors and better human beings as such. So excellent. We have excellent academicians in our panel. We have good people who are good in finance. We have people who are good in conference presentations. So we'll take the help of all the different endocrinologists from India to have this particular discussion. So without further ado, I think first I will call upon the panelist for the adolescent PCOS discussion. For that, I will invite Dr. Soham Mukherjee, who's now a consultant endocrinologist at PGI Chandigarh. Dr. Sangeeta Santosh. She is an endocrinologist from Tanishta Center in Hyderabad. Dr. Soumya Inamdar. She is from the Palette Super Speciality Clinic in Hubli. And Dr. Anirudh Shetty, who's from Narayana Health in Bangalore. All of them are young and budding endocrinologists. I cannot use the word budding because already we have people who have reached the associate professor range, also additional professor range in PGI Chandigarh. But all of them are very dynamic in whatever they do. They are good presenters. If you look at the papers that they have all published, they are amazing. So I hand it over to Dr. Nayanatara, who is a consultant endocrinologist, she works at AIG Hospital in Hyderabad and also is a part of the Magna Centers team. So over to you, Dr. Nayanatara.
Thank you for the kind introduction, sir. So without further ado, I would like to go ahead with the presentation. So today we're going to discuss adolescent PCOS. This is going to be a panel discussion. So coming to the case, this is a 14-year-old girl who had attained menarche at 11 years of age and who had presented with complaints to the OPD with complaints of increased facial hair for the last 1 year, menstrual irregularities since her menarche. She gets one cycle in 3 to 4 months, and history of withdrawal to progesterone is present. Hello, can you hear me? I think the host had. Am I audible?
You're the only person who's audible now.
Okay, great. So coming to the history of the patient, she had menstrual irregularities since her menarche, increased facial hair for the last 1 year. She has history of withdrawal to progesterone, acne, which the dermatologist felt was difficult to treat for the last 1 year. And the sister, her own sister, who's elder to her, has a similar history. And the patient in particular is not on medications at present. So in this, what we find is a 14-year-old girl who had attained menarche at 11, so which means she's 3 years post-menarche, and she's having menstrual irregularities starting since the beginning. She's having increased facial hair only for the last 1 year. She's withdrawing to progesterone, which means the estrogen part is good, so probably she's suffering from anovulation. Acne, which the dermatologist felt was difficult to treat, which means that we have to think in terms of hyperandrogenism. Sister has a similar history, which means the family history has to be taken into consideration, and the conditions which are familial with irregular cycles have to be considered in terms of PCOS, CAH, thyroid history, GRS, POI. And she's currently not on any medications which could affect her cycles. So now, sir, I would like to ask Dr. Soham, how do we define menstrual irregularities in an adolescent?
So it is actually a tricky question because the pubertal development is still ongoing and the HPG axis is still maturing. And initially, a few years back, it was considered up to 6 years there may be menstrual irregularity after menarche. But after that, some large studies came, including a Dutch study, and which have shown that within 1 year of menarche, the menstrual irregularity is a normal phenomenon. Between 1 to 3 years, actually, if the menstrual cycle duration is less than 21 days or more than 45 days, it is considered abnormal. And more than 3 years post menarche, if it is less than 21 days or more than 35 days, then it is considered abnormal. If in any particular cycle, 1 year post menarche, the duration is more than 90 days, that's more than 3 months, as in your case, then it is absolutely abnormal and you need to evaluate the patient. Further, if some patient has primary amenorrhea, even at 15 years of age, or post-thelarchy, within 3 years, menstruation has not started or has not initiated, that is still there is primary amenorrhea, then also you need to evaluate the patient. Another thing is if there is less than 8 cycle per year, then also you have to consider that abnormal.
Right, sir.
So
thank you so
I think
much.
that clarifies your question.
Yes, thank you so much. Dr. Sangeeta, is it important to know what is a gynecological years in adolescent PCOS? What is the significance of the same, and how do we define gynecological years?
What I understood from the question is what sir has answered, like how many years the kid or the child is into the puberty, or when did she attain menarche. So here what I would also suggest is like the duration, when did the child attain menarche, and how many years the patient is having these cycles, that will be important over here. That is what I understood. So if anybody wants to give any other inputs here.
Okay, ma'am. So I'll explain about gynecological years in the coming slides. How do we define and grade hirsutism? And is there any Indian cutoff, Dr. Soumya?
Yes, like firstly to define hirsutism, it is the presence of the terminal hair in females in the male pattern distribution areas. We normally have the vellus and terminal hair. Vellus hair is soft, thin, and less pigmented, and it is non-medulated. Terminal hair are usually thick, medulated. They are dark pigmented compared to the vellus hair, and they can be stronger or even longer. When normally this terminal hair is present in the scalp area, eyebrows, and eyelashes in prepubertal and pubertal or adults, everyone. But at the time of puberty, under the influence of androgens like the testosterone and DHT or any other forms, the androgens in high levels also, there is appearance of axillary hair and pubic hair in both males and females. And in males, we can see the other hair in other areas like in the face, in that beard and mustache area. We can see the hair in chest area, upper and lower abdomen, back area, arms and thighs. So when such kind of distribution is seen in females, we call that as hirsutism. The hirsutism, the occurrence of hirsutism can be because of the presence of high androgen levels, or it could be just because the hair follicles are very sensitive to the androgens. We have a grading system for hirsutism. The most commonly or the widely used hirsutism grading system is the modified Ferriman-Galway scoring. It takes into consideration the appearance of this abnormal facial and body hair in the 9 areas, in the upper lip, chin area, in the chest, upper and lower abdomen, upper and lower back, arms and thighs. So in these all 9 areas, it is graded from 0 to 4, where 0 means the presence of vellus hair, and 1 to 4 tells about the distribution and density of the this terminal hair. And based on this, the grading, when the score what we can get is from 0 to 36. Anything which is more than 8 is considered abnormal usually, but the severity of hirsutism were in different ethnicities. Whatever the first grading system was designed, it was mainly from the white population. The severity of hirsutism differs in different ethnicities. There is different cutoff for different ethnicities also. Like in the Mediterraneans have got a little higher cutoff of more than 9. The Asians have got a cutoff of less than 2. Like even more than 2 is considered high for the Asian population. But whereas in India, we don't have many widespread studies like to have a regional data. But there has been a recent study published in the year 2024, where they have given a cutoff for South Indians, especially. It was done by Dr. Vijay Sathi sir and other team members, where the cutoff of more than 5 is considered as significant hirsutism we can consider for South Indians. And the grading of, by the score of hirsutism, whatever we get, generally it is divided into 3 severity grades. 8 to 16 is mild, 8 to 15 is mild, 16 to 25 is moderate, and more than 25 is severe hirsutism.
Great, Dr. Soumya. Thank you for that. Dr. Anirudh, could the type of acne direct towards a diagnosis?
Yeah. So generally, we say the pustular acne points towards hyperandrogenemia, while papular acne suggests pure glucocorticoid excess. Also, we need to understand where the androgen receptors are located. So it's in the PSU, in the pilosebaceous unit. It's located in the sebaceous gland and dermal papillae. So there is not only increase in the presence of hyperandrogenemia, there is not only increased sebum production, but also the lipid ratio in the sebum is altered. That results in increased chances of acne. And also the number of acne is also important. if there are more than 10 inflammatory acnes, then it is that is called as moderate to severe. You can grade acne as mild, moderate, and severe based on the numbers. So if it is more than 10, that means it's moderate. More than 25 means severe. So if it's moderate to severe in number, then you have to think of hyperandrogenemia as the cause, and you have to evaluate for it.
Right. Seconded, Dr. Anirudh. So, defining menstrual irregularities, Dr. Soham has already elaborated in detail, so I will be skipping this slide. So, coming to gynecological years, the gynecological years is how many years post-menarche. These are the gynecological years, and within 8 gynecological years, it should still be considered adolescent PCOS as a general recommendation given by the committee. So what we have to remember is, even though a woman might menstruate at menarche at 12 and the PCOS are set in maybe at 20, we should still consider, we could still consider adolescent PCOS is what they have proposed, because the etiologies at present within that same 8 gynecological years are almost similar. So hence that 8 gynecological years is important. Now, coming to hirsutism, Dr. Soumya has already mentioned this is the modified Ferriman-Galloway score. So just a little bit more about terminal versus vellus hair. She already mentioned the thing, but we also have to remember that the growth rate for terminal hair is higher than vellus hair. So what are the modifications that were made to the FG score? We usually say it's a modified Ferriman-Galloway. What was the modification made? These were the sites that were reduced from 11 to 9. And what were the drawbacks of FJ score that we use? It's observer dependent and does not include the sideburns, the nape of the neck, phalangeal and perianal areas. It is validated in adults mostly, though we still use it in adolescents. There are studies that have been done with modified Ferriman-Galloway score in adolescents, but when you look at the actual score that was developed, it was actually developed in adults. So coming to the South Indian population, thus Dr. Soumya has already mentioned that the cutoff of 5 in South Indian population for the evaluation of hirsutism by Dr. Vijay Sarathi sir. And there was another study done in Chennai which showed a modified Ferriman-Galloway score of more than 6 to be hirsute, and this was done in Chennai. So the diagnostic criteria for adolescent PCOS
I think Nayantara is frozen right now.
Normal for age or gynecological age, and persistent symptoms for more than 1 or 2 years. Clinical and or biological evidence of hyperandrogenism. Hirsutism, if moderate to severe, is clinical evidence of hyperandrogenism. Elevation of serum total or free testosterone by a specialty-specific reference essay is biochemical evidence of hyperandrogenism. So there are only 2 things: ovulatory dysfunction and hyperandrogenism. The ultrasound has not been mentioned over here. So that is one thing that we need to remember. So coming to what Dr. Anirudh has already mentioned, when do we consider acne significant in adolescents? Because most of the adolescents do have some acne. So when do we consider it as significant? When you have moderate to severe comedonal or moderate inflammatory acne. And he's already mentioned the number of lesions for each. So the comedonal acne, if it is more than 11 to 25 lesions more, so that is moderate to severe acne. Or if it is 11 to 25 in moderate acne, we consider it to be significant. And I have put up a picture of comedonal acne, which has whiteheads and comedones. This is the inflammatory acne, which has more pustules and papules and nodules. So coming to the examination part of this patient, the BP was 130/80, BMI was 30 kg per meter square, waist-hip ratio was 1.2. There was no goiter present. Acanthosis nigricans was present at the nape of the neck. Acne was present over the face and the back. Hirsutism was present over the face, upper lips, chin, abdomen, and upper back. And the Ferriman-Galloway score came up to around 8. No other signs of virilization were present. No feature suggestive of acromegaly, Cushing's, hyperprolactinemia, or hypothyroidism were present. So coming to Dr. Soham sir, can you please explain PCOS is a diagnosis of exclusion. So what all conditions should be ruled out before we label a patient as PCOS?
So I remember in my DM years, what my professor used to tell me, PCOS is a clinical diagnosis. You require hirsutism, you require oligoanovulation in the form of menstrual irregularity, you make the diagnosis. So, but important is to exclude the differentials. So what are those important differentials? 3 important differentials are hypothyroidism, hyperprolactinemia, and NCCH, non-classical congenital adrenal hyperplasia. You have to exclude these 3 conditions. Apart from this, androgen secreting tumors, that is ovarian, that may be adrenal androgen secreting tumor. Apart from this, if clinical suspicion is high, like in Cushing syndrome, you will have some stigmata and all those things. And glucocorticoid resistance syndrome, another differential. But glucocorticoid resistance syndrome may have hypertension, hypokalemia, other features as well.
Yes, sir.
So apart from these, some drugs may cause PCO-like phenotypes, like anti-epileptic valproate, or maybe androgenic anabolic steroid, or progesterone preparation, denazole, like those drugs has to be excluded. And some ethnic variation can be there, as my previous speakers are also mentioning, that hirsutism varies from race to race and from different ethnicity also. So I think this differential should be considered and should be excluded before diagnosing PCOS.
Thank you, sir. Dr. Sangeeta ma'am, what are the signs specific to the conditions which mimic PCOS?
Now that sir has explained what are all the conditions should be excluded, I think my job is easy. So we'll be trying to look for all these signs. So if we examine the patient from top to bottom, what we call as head to toe examination or the general examination. So first and foremost, all of us know the first diagnosis which we should rule out is the hypothyroidism. So we look for the hypothyroid features, that is you look for goiter, you look for the coarse features, facial features, you look for the puffiness of the face, or if it's helpful, I don't know how far it will be helpful, but if the patient is short stature, so that also may give us a pointing towards the hypothyroidism. Then after that, you go for the other important cause we should try to exclude, that is the cortisol excess. So for that, you look for any Cushingoid features, as sir was mentioning about the deposition of the fat, or what we generally look for, stray. Then you look for the purplish stray, and obesity. Again, the truncal obesity part you can look for. And then other than this, you can look for the other features like hypertension, what sir was mentioning. If the patient is having any hypertension, rare causes we can try to look for. Then the virilization, like based on the degree of the virilization also, we can try to think about what could be the other causes. Other than this, if any galacturia, very unlikely that patient will be having galacturia and the prolactin will be so highly elevated if the patient is presenting with only like PCOS picture. But that is also definitely one of the differential. So we should look for that also when we are trying to look for or examining the patient to rule out the conditions which can mimic the PCOS. Then other than this, if like you are comfortable and you can look for the virilization features, then you can look for the clitoromegaly also. Then any syndromic features, but that may not be significant in this case. If we are particularly talking about this case, it may not be significant in this case. So I think most of the causes we have tried to analyze and exclude. So this is what
Right,
I think will mimic the PCOS.
Seconded, ma'am. Seconded. Dr. Swami, what are the other signs of virilization that should be noted other than the hirsutism that we have noted and acne that we have noted? What other things, signs of virilization that we should be noting?
Deepening of voice, increase in the muscle mass, and breast atrophy, and clitoromegaly. And if there's a excessive seborrhea or any hidradenitis suppura, all those we have to just look for any other, like these will be the other signs of virilization.
That's great. Dr. Anirudh, is metabolic syndrome a part of the PCOS?
So around 30% of PCOS patients, adolescent patients, have metabolic syndrome. However, it is not required for the diagnosis, but it's strongly associated with it, as you've already mentioned. And clinically, it's important because these patients are at an increased risk of cardiovascular disease as well as type 2 diabetes. Hence, clinically, it's important to pick them up early.
Seconded, Anirudh, sir. So coming to the differentials that I had considered in this patient, we went ahead with, these are the broad headings that I always put my patients under when they come in with hyperandrogenism, acne, and irregular cycles. So because androgens come from two areas in a woman, one is the ovary and the other one is the adrenal, and the types of androgens that we usually find is 50% is usually testosterone, then we have androstenedione, DHEA, and DHEAS. So where is this androgens actually coming from? Is it from the ovary, like the functional ovarian hyperandrogenism, which is a primary PCOS, or is it a secondary PCOS, secondary to some severe insulin resistance, acromegaly, CAH with adrenal rest? So is there a secondary PCOS? That is something that I was always considering. Is there a functional adrenal hyperandrogenism, like how we find in virilizing CAH, increased hyperprolactinemia, Cushing's, GRS, like Shoham sir had already mentioned? Is there a peripheral androgen production, like how we have in obesity or idiopathic hyperandrogenism? Is there a tumoral hyperandrogenism, that which Dr. Shoham has already mentioned, like how we have ovarian tumors or we have adrenal tumors, wherein there is a higher amount of hirsutism and there is acne and there is irregular cycles? And was the patient on any drugs? So I had asked patient multiple times, but she denied it. So, but still, I have put it as a differential diagnosis. So I approach like this when I'm going into differentials of these three conditions to put together. So, Dr. Soham, how do we go about investigating the case? Now that we have differentials in our basket, how do we go about narrowing down and how do we go about investigating the case?
Yes. So basically, we have to exclude the differentials only. So for hypothyroidism, TSH, NCCH, you have to do a 17-hydroxyprogesterone. If the patient has irregular menses, you can do it at any day, 8 a.m. And for hyperprolactinemia, prolactin. For androgen secreting tumors, we can do total testosterone or free testosterone level if the facilities are available, or DHEAS level. If DHEAS is very high, that is more than 8 microgram per ml or 800 microgram per DL, that suggests adrenal androgen secreting tumor. I mean, if the testosterone is very high, I mean to say 6 or 7 nanomole per liter or more than that, then you should suspect ovarian androgen producing tumor as well. Apart from this, the other condition like Cushing's and GRS can be excluded by doing 8M cortisol ACTH and ONDST. Because if the ONDST is suppressible, then the both conditions being ruled out. So, and other condition are drug history and all those has to be taken. Apart from this, I would like to do a LH, FSH and estradiol level, because sometimes hypothalamic anovulation can be ruled out by this way, and they can present with oligomenorrhea and all those things. But patients are usually thin built, so the possibility is less in this case. For other investigation like USG, pelvis, and all those things are less useful in adolescents PCOS. I think my colleagues will discuss this later on, so I'll not advise in this patient. And other things are component of metabolic syndrome. We have to exclude the component of metabolic syndrome, including impaired fasting glucose, impaired glucose tolerance, type 2 diabetes, hypertension, dyslipidemia. All those components of metabolic syndrome has to be ruled. I think I should investigate the patient like that.
Okay, sir. Thank you so much for the insight. Sangeeta ma'am, what is AMH and how does it help in PCOS diagnosis? Should an AMH be done in this case? Because AMH is all the rage after PCOS diagnosis has come out. I'm seeing a lot of patients coming in with AMH reports. Can you please elaborate? Yeah.
Yeah, I was about to tell the same thing. Off late, we see a lot of these AMH reports nowadays.
Yeah.
So now, what I understood from the literature, frankly speaking, I personally don't advise for any AMH right now for any patients. But what I have seen in the literature and what the reports I have seen in the patients is AMH is only one of the investigations which has been suggested for PCOS. There is no clear-cut recommendation or clear-cut cutoff where an AMH can be used. Yes, definitely AMH may be useful in the diagnosis of PCOS, but there is no need to definitely get the AMH, because AMH is it has been observed in various studies that AMH is increased in the PCOS, especially based on the phenotype of the PCOS also. If the patient is having the oligomenorrhea along with the hyperandrogenism and the ultrasound picture, these patients who are falling in the phenotype A, these patients are having higher levels of AMH compared to the other phenotypes. It is correlating much better. But overall also, if you see in the PCOS patients compared to the normal patients, the AMH levels are increased. But the main issue is we don't have the clear cutoff. What is the cutoff to be taken? And especially in the adolescent age group. So adolescent age group, there are various studies which have recommended the cutoff to be somewhere between 6 to 7. Physiologically itself, AMH levels are slightly higher side in the adolescents, and as the age advances, usually they tend to decrease. So that is the physiology of the normal reproductive system also. So because of all all these things, AMH is not that much definitive diagnostic for the PCOS. And in this case, already patient is presenting to us with menstrual irregularities as well as hyperandrogenism, what we have seen in the clinical examination till now. What we have proceeded in this case, as such, we did not come to the investigations. So here, I think this is not recommended in this case. There is no need to do in this case. And in the adults also, there are studies wherein the AMH cutoffs have been mentioned, but I think practically it's not that useful even right now, even the adults. Some studies have shown that it is less than 4.2 to 4.3 what they are taking, but the definitive diagnostic is above 5.
Right. Seconded, ma'am. We don't have an ethnic specific cutoff for AMH, and in adolescents, it's much less reliable than in adults. So, Dr. Soumya, should a pelvic ultrasound be done? If so, when should it be done? And what are the details we should be asking the radiologist to look for?
In this case, we need not go ahead with pelvic ultrasound. First of all, it is not utilized in the diagnosis of adolescent PCOS. The only two criteria are this one. Presence of menstrual
Hyperandrogenism,
irregularity and the clinical or biochemical hyperandrogenemia. So it can only be done after 8 years of the gynecological age. And whenever we are asking for pelvic ultrasound, we should look for two main information. That is either if you are asking for a transabdominal scan, follicular number per section plus ovarian volume. If they are doing transvaginal scan, then it should be follicular count per ovary and the ovarian volume. So if we look at the follicular number per section, which is usually given from the transabdominal scan, if the count is more than or equal to 10, that is suggestive of PCOS, and ovarian volume more than equal to 10 ml. And if we look for the transvaginal scan, in that follicular number per ovary, that is the entire follicular count in the entire ovary. If it is more than equal to 20, it is suggestive of PCOS morphology.
Right.
And through transvaginal scan, it is more idealistic than transabdominal scan. Wherever possible, it needs to be done because it will give an entire ovarian follicular count than the cross-sectional count.
Right. Right. So, Dr. Anirudh, if there is a PCO morphology on USG, does that make the patient PCOS?
No, as already told, it doesn't make the patient PCOS. Ultrasound is not recommended in pelvic ultrasound is not recommended if the gynecological age is less than 8 years. And the reason being the multifollicular ovaries are very
Exactly.
common
Yes.
in this age group. So it doesn't make the patient PCOS, even if it is there in ultrasound.
Right. Seconded, Anirudh, sir. Now, coming to the investigations that I had done in this patient, if we see the LH is 17.5, FSH is 8.08, these were all done on the day 2 of cycle. Total testosterone is 82.08 nanogram per DL. DHEAS is 350 nanogram per DL. 17 OHP is 0.88 nanogram per ml. TSH is 4.3, estradiol is 62.3, 8 AM serum cortisol is 9.11, ONDST is suppressed, sodium is slightly low, 135, potassium is normal, creatinine is normal. So creatinine is normal, prolactin is normal, FBS, HbA1c, lipid profile are all normal. Complete blood count is normal. And I had done a USG pelvis in this patient. Right ovary showed a 16 cc, left ovary showed a 20 cc, and endometrial thickness was a 6 mm. But the reason why I put this up is to say that USG pelvis is not indicated in this patient. And this patient had actually come in with these reports to me. So coming to, is there some other investigation that I should have done in this case, Dr. Sangeeta ma'am? Have I missed something?
So for completion's sake, I think you did a good job over here. But for completion's sake, if we want to discuss further what else could have been done, so what I can think of is like, but just as I was telling, ONDST already indicates that most probably we can rule out the glucocorticoid resistance because it's suppressed. But if you want to just for completion's sake, you can go for 4 PM cortisol. And the other thing which we can recommend is the sex hormone binding globulin, just to look for the free testosterone index. And the other thing which I would recommend in this patient is GTT, because her HbA1c is 6.1. So just to look for GTT, it is a much better way of explaining to the patient, I guess, to tell them that this is the seriousness of your problem. So just take care. Otherwise, there is every chance you'll land up with diabetes. So lifestyle modifications, to emphasize the need and the significance of lifestyle modifications, probably that could help us. So I could think of these investigations. Otherwise, I think practically you have covered all the investigations needed. In fact, as you have said, I felt 2 or 3 are like more than required also.
Correct.
Basically.
Correct. Okay. So, Dr. Soumya, do we have a diagnosis yet, or do we need to go dig deeper?
I think we have a diagnosis here because we have ruled out the most of the secondary causes of hyperandrogenism or this hirsutism or secondary causes of PCOS as such. So it's looking more of a adolescent PCOS case.
Right. So, Dr. Anirudh, how do we investigate the obesity in this case? Are these investigations enough, or do we need to do further?
Yeah, so we have, I think that even in the history wise, there is no history of any protein feature suggestive of protein catabolism, and ONDST is suppressible, so that almost rules out Cushing's syndrome, and also there is no clinical features of hypothyroidism, and TSH is normal, so you have ruled out hypothyroidism as well. Probably I would also want to look at the LFTs if it has not been done, if I'm right. Probably an LFT
Right,
to look for any
right.
transaminitis. An ALT level of more than 80 in adolescents is considered to be significant, and you have to do a fibroscan or further investigation. And the other thing is any history of snoring to rule out obstructive sleep apnea, and sleep study might be needed in that case.
Sure.
Other things I think have been covered.
Sure, sure. So, Dr. Soham sir, what are the different phenotypes of PCOS, and do the adult phenotypes apply to adolescent PCOS as well?
So basically, if I classify the phenotype, you will understand whether it is applicable or not. So the phenotype is based on the Rotterdam criteria.
Right.
And it has 4 phenotypes. So phenotype A is, or A and B is also known as classic form of PCOS. In the phenotype A, also known as complete PCOS, there is hyperandrogenism, ovulatory dysfunction, as well as PCOS morphology. All the 3 components are there of Rotterdam criteria. In the phenotype B, the PCOS criteria is not there. There is only hyperandrogenism and ovulatory dysfunction. The phenotype C is also known as ovulatory PCOS, where hyperandrogenism with PCOS morphology. And phenotype D is non-hyperandrogenism phenotype. Here, the ovulatory dysfunction is there along with the PCOS morphology. You see, in A, C, D, in all the phenotypes, all the 3 phenotypes, A, C, D, there is PCOS morphology, which is not useful in adolescent PCOS.
Right.
In adolescent period, only type B is applicable. So other phenotype is irrelevant here. This classification is more for adult PCOS.
Right. Thank you for mentioning that, sir. Now, coming to the free testosterone, which ma'am has already mentioned, this ideally has to be done via equilibrium dialysis. We see a lot of free testosterone reports being on our table, but however, it's not via equilibrium dialysis, obviously, so these are not reliable. So the other way we can go about it is to do a free androgen index. So to do it, how do we do that? We take a total testosterone done by eCLEA divided by the SHBG. Both should be in the same units and into 100. So if we get it more than 5, we usually say it that this is a testosterone increased in this patient. But Vermeulen came up with something, said that, okay, SHBG, testosterone is bound to SHBG only 50% of the 50%, but the rest of the 50% is bound to the albumin. So what about that testosterone? So he came up with a complex formula, which included albumin also in this. Now, when do we assess the testosterone? If the patient is on OCP, please stop for 3 months and reassess testosterone. Now, this Dr. Soham has already beautifully explained. So, Soham sir, can we have the treatment strategy in this case? Like briefly, how do we approach the treatment strategy of this case?
Dr. Nayanthara, we'll have to wrap it up. So can all the panelists tell very quickly what the answers to these questions? Very quickly.
So I will only outline. Detail will be described by my colleagues. So you have to cause weight reduction, diet, lifestyle modification, and graded exercises, exercise protocol. We have to address the oligonucleation, that is the oligomenorrhea part. We have to address the hirsutism parts. We have to address the fertility issues in future. We have to counsel at least. And we also address all the component of metabolic syndrome has to be screened and treated if required, and also address the psychosocial issues.
Right, sir. I think hirsutism and acne and PCOS, ma'am, in 2 sentences, if you could just sum it up.
That's what. So the basic thing is, again, basically we have to see the grade, like the severity matters whenever we are trying to treat. So, but here again, the basic will be to treat the etiology per se. So we'll be targeting the first line of treatment will be again OC pills that will be helping us throughout, and then other than that we'll be going for the either the mechanical measures or the chemical, in the sense we give the medication to the patient. So again, it depends on the severity. So the various options all of us know. So other than OCPs, we have spironolactone, we have the flutamide, then the finasteride, etc. And for the acne, again, we usually go for the cosmetic treatment. That is, again, you can either go for, if it's mild, you can just ask for like keep the face clean, and they can just go with the simple supportive measures. If it is moderate, then you can go for the topical. And if it is very severe, probably oral will be required. But always I would recommend to take our colleague's dermatologist opinion, because it should always go hand in hand. So I think in short, I would try to wrap up this.
Thank you, ma'am. Soumya, oligomenorrhea and PCOS?
In this patient, I would like to emphasize on lifestyle changes in the terms of exercise, diet, and all. In addition to that, OC pills would help in addressing the oligomenorrhea.
Right. Thank you, Soumya. Anirudh, sir, addressing fertility aspects in PCOS?
So
Mother
first of
wants to
all,
know. Yeah.
mother, So first of all, we should reassure the mother and tell her that many of these patients can achieve pregnancy naturally, and only some of them will require ovulation induction with the help of letrozole or clomiphene citrate, and weight reduction, that is especially in obese PCOS. It would go a long way in increasing the fertility chances. That has to be emphasized.
Yes. Thank you, sir. I think we'll wrap up here.
Excellent discussion, I should say. And it was very extensively covered by Dr. Nayantara and all the panelists. So I would like to thank all of them individually and as a group for helping us get together this session. So we'll go to session 2 right now, and I'll invite Dr. Lakshmi to introduce the speaker and the topic.
Thank you, sir. So after this very academic session, which we all enjoyed a lot, we are going to a slightly non-academic talk. I'm looking forward to this talk. So it's my honor to introduce Dr. Bipin Sethi, sir, who's a senior consultant endocrinologist from Care Hospitals, Hyderabad. So sir has been a role model as a speaker for endocrinologists across the country for his eloquent, to the point, and humorous presentations. And I've been a big fan of sir's talks in all the conferences that I've had the privilege of listening to. So sir will be presenting in a scientific conference, do's and don'ts. And over to you, sir.
Thank you for some kind of introduction, which I don't actually deserve. Usually I'm calling for item numbers, and I think this is something that is the case today as well. I have not made my talk very formal in terms of what are the do's, what are the don'ts. They'll probably keep creeping up in between, and really don't deserve that. There have been better speakers, and Professor Dash and Dr. Shamsundar have been my role models. So I will now see if the slides can move. They aren't moving now, certainly. Yeah. So the first thing that happens to you when you are called for a meeting is why me? And this happens always when Santosh calls me. So there's so many other people who can give this talk, why me? But we should get over that feeling. Never ask to change the topic. Rather, you should feel that you've been wanted, and you should live up to the expectation that are raised from out of you for that meeting. I think what's the most important thing is we should prepare for the topic. And in fact, it happens that most often it enhances your knowledge much more than the knowledge of the audience, which may or may not be present at the point of moment because they are either, stalwarts or they are outstanding people, whatever it is, but your knowledge is enhanced. We should prepare the slides ourselves. And I'll come to that a little bit later. Even if we don't have the time to prepare slides ourselves, I think we should overall have the ownership, supervise, and finally see the final content. you're asked to speak on, let's say, the some complex issue about the anti-Mullerian hormone in women, in hirsute people, something which we haven't done, or role of testes in bone testis crosstalk. You don't vomit everything that you learned in that meeting just to tell people that you referred to any GM, Lancet, Nature, reviews, etc. Give them the gist, because that's very important. They need not go through all the trouble that you have gone, and they should be given a message in a very clear talk. You should know the audience. This guy is trying to play bean to a buffalo. I don't think that my audience is of that type, but we should know what our audience is. Often we try to find out is physicians, the gynecologists, pediatrician, because the content that we have might have to be differentially discussed with them. Today, we had a talk on PCOS. If the audience is, let's say, pediatricians, which seldom is the case, then we would have to talk about what is the adolescence, what is the age group, and all that. But it's important to know, is it physicians? Are we talking to MBBS people? Are we talking to MD? Are we talking to DM people? Because then you make your talk relevant. You also know what the knowledge gaps are. And also, you know what the expectations are from the topic and also from you. Slides I will make. How should the content be delivered? Many times, people who speak nicely have asked them, they say that I get my toilet ideas when I'm taking bath. They're constantly writing, making notes, and refining slides even till the very end. Don't torture the audience with the slide. I think I still be doing that today. Distill the content, concentrate it, and from your side, offer the best end product. My friend says that the painters and sculptors, they don't finish the product, they just abandon it. After you can't do anything with it, you say, okay, this is all that I can produce, but give the best possible product that you can produce. This is the most important thing. Julius Caesar, of course, took this in his stride, and then he divorced his wife. But if you are considered important, if you're considered a leader, if you're considered a person who is important, be of the type and kind that the content that you give should be such that people can't say that in the morning he said ACE inhibitors are the best, evening he said ARBs are the best, and next day morning he said diuretics are the best solution. I think that is nonsensical. I have seen foreign speakers doing it. I've seen our own colleagues doing it. If there is no ambiguity, be vehement. It could be efficiency of tirzepatide versus liraglutide or semaglutide. Nobody will question if you say that tirzepatide is maximum weight loss in human beings by. But if you are saying that liraglutide is as important to do, second generation insulins, the differences are usually pharma driven. So you don't say in one meeting that degludec is better. Second meeting you say the glargine 300 is better. Third one you say no, glargine 100 is the best. And that is nonsense. The people lose faith in you. And I think there is no need to do that. You speak the truth if it is there. It's there. Otherwise, you say that, okay, there are, for example, degludec and also glargine 300. There have been papers published by the same laboratory saying one is better than the other. So much so that the person who manages that laboratory had to write an editorial as to why those differences were there. So I think we need not get drawn into those content. What is there after 15 minutes of your talk? Everything is over. So you don't have to defend one or the other. Personal anecdotes, stay away from them. In my case, I saw one patient that lost 43 who is interested. Real world studies, RCTs have greater numbers, relevance, and weightage than anyone else. No, I have seen 5 patients who responded very well. I saw one patient who was infertile and we gave her Aldoxin 12.5 milligrams or Tylenol 12 milligrams, whatever it is, and that patient had multiple pregnancies. Because of that, I believe I treat everybody with well, not in that manner. Stick to time. Go in advance. Sometimes you are made to wait. Sometimes you're upgraded. For example, nobody upgraded me today. I was meant to wait. But it doesn't matter, go in advance. Because that takes pressure off the organizers. Okay, so and so has come. And sometimes people say, okay, if you call that fellow, he will be on time. And also, they will say you talk for 20 minutes. Then when some very important person will come and they say, oh, can you talk for 2 minutes? Can you talk? Can you finish the talk in 5 minutes? You should. The slides are yours. You can finish them in 3 minutes. But if slides are made by somebody else, you would not know. In the meeting that we have, a slide on pathophysiology of diabetes touched upon by 100 people, or at least 4 people. You don't concentrate on this omnious octet or the 11 things that are there or the 12 things are there. You just say this has been shown, and then it just saves your time and also saves the audience from the torture. And I said, prepare the slides yourself. Have max 4 or 5 points.
So your what breaking a little bit. Can you just switch off the video for some time? It's breaking and coming now. The voice.
I will. Yeah, I will. I'll just see. Only thing is I have to find out how to do that. Yeah, that's nice. Even as such, I'm not as good looking as you are, Santosh, so don't worry. So prepare the slides and 3 to 4 to 5 bullet points will do. Don't make sentences. I prefer black and white. You may prefer green but see this. Take into consideration that projections systems or different parts of the country or wherever you speak may not be the same. And all these colorful things may not come. Sometimes when you want attention to be drawn to a particular person or to you because you want to say something important, you can put a blank slide. Everybody will look at you. And then you can say that, okay, fine, this is the obvious thing. We have made a mistake or whatever it is. So this is something like giving a gap to the audience. And our complex slides, and if you say that, I have seen many speakers saying that, I think we need to show this slide. If it is not to be shown, why did you make it? And why do you want to torture them? So don't hide all the slides which you want to skip. Then comes this, start the topic with basics. Build up, maintain the flow, stay focused. You can cut relevant jokes. You can intersperse with relevant images, for instance. For fear of hypoglycemia, I often show this slide. A pseudodomicil is not to tell people that I can't even pronounce it properly, that fear of hypoglycemia is more important than hypoglycemia occurrence itself. Or if there is a very important thing, like the drug that is the gold standard, tirzepatide is the gold standard for weight loss. This you can show this slide of Josephine being crowned by Napoleon. Very unique. So this thing comes from Bivar. आज मेरे पास building है, property. The molecule has got something great, and we use this for SGLT2. All the molecules are good at reducing glucose level, but this is something different, so you can use it. Well, you can choose slides of different kinds. Some people use Alice in Wonderland, some people use Gulliver, some people, but it's okay. I said in the beginning, which I didn't do, or toward the end, thank the organizers. Because if you don't, I know of organizers who don't call you, say, thanks. Thank the audience for having borne with you. And you can have a picture of the city or state you belong to, but don't bore people with, I come from Hyderabad, this is the Statue of Equality, this is the high-tech city. They're not interested. They come to listen to you. They don't. They actually have seen those places very much more than you. Don't say anything for the sake of saying. I had the misfortune of asking a speaker a question who said, for nephropathy patients, insulin is a must. So I said, are you sure, Dr. So-and-so? Well, I was saying only for the sake of saying. I said, the audience doesn't know that you were saying things just for the sake of saying. And if you have made a mistake, please admit that mistake. That I think that was a slip of a tongue. It happens. We're all human, and I make mistakes than anybody else in the world. And I say, okay, I made a mistake. So own your mistakes. Know your slides. Sometimes what happens is slide becomes blank. The projector doesn't work. You should know the contents also. Load it. When you go to a meeting, load it. If you are in a meeting like this, check it before presentation, because organizers are too busy. They'll say, apart from 1 or 2 people, they'll say, send the slides. When you go there, they'll say, have you got a copy? Have you got a pen drive? Better go load it yourself, then you will know all the whole thing. I had the misfortune of loading some slides in the scientific forum. Out of 15 slides, 7 got lost. I knew that 7 slides are lost, but nobody else knew, because I knew what the slides were and I covered them up. If you have something very important and you think that you might discuss a very closed group meeting, you can have some backup slides, some hidden slides. Presentation, now this for example is jarring. All the fonts were so good, and now suddenly it has changed. To avoid this kind of things, I have put it on purpose. So you are not showcasing your knowledge. You are adding value to your own knowledge and to the knowledge of the audience. So it's about knowledge sharing. You're not giving commandments. So avoid playing to the galleries. I've seen speakers, they just stand as though, oh my God, somebody is descended from heaven and giving us those commandments. That is not required. You've been given a chance to present your data for just 10-15 minutes, nothing more, nothing less. So don't think that if something great has happened. You're not presenting, giving the presidential audition in India, even they speak nicely. Be candid. Don't be tense. It may be your first thing, but you know about the topic more than anybody else. Be firm. Often, unfortunately, this is taken as being rude. I was asked once that I think this was some trial which we had read about, and we asked the person in question that was the trial done with empagliflozin alone, or 3 more drugs were done? And then that person thought that we were rude. We should be firm, however. Also, often the time we have this habit, especially when we go to maybe Tamil Nadu, or maybe up north, people break into Hindi like anything, as though they know, everybody knows Tamil, everybody knows it. Hey, the whole fun is lost, and you feel that you come into a meeting where people are don't want to talk to you, because the moment you go into language, it is good for a select audience, but not for everybody. You want for an audience which is 10 people. Half of them know Punjabi, half of them don't know. You can tell 1 or 2 words in Punjabi, but matlab, my कहना चाह रहा था, who is interested to speak in a language which everybody understands. Interaction is something which we should allow, and I think there is some interaction at the end of this. If you put these some multiple choice questions, choose one of them, most often they fail. So unless there is a mandate from the organization that's paying you for that lecture, better not to have MCQs, because most people would not answer this. I know that this is a very high-tech forum and you may disagree with it, but try putting a question to the audience. They just look here and there. But be respectful to the person who asks the question. My father used to say that the questions are never stupid, answers are. If you have some bouncers, I have seen this happen. Many people have done this to me also. If there's a very uneasy question, they say, ask Dr. Santosh, ask Dr. Vipin, ask Dr. Mathur. You mostly score on the low one, but better if somebody has asked you a question like you are talking on postprandial hyperglycemia, and somebody says, how do you manage glycemia and pregnancy? I think you can say this question is not in the purview of my talk. In conclusion, making slides and presentation is an art, like poetry. Poets also use the same words. We also use the same words. Cooking, same ingredients are being used, but then my wife's cooking is better than everybody else's. Why? Because she has a knack. Learning is a continuous process. When you are asked to present, you are learning more than the audience. Audience may not learn anything. My teachers for this kind of presentation have been everyone whom I have had the chance to listen to, and specifically my mentors, Dr. Ajay Dash and Dr. Shamsundar. With that, I thank you very much, and I'm told that there are some questions which I should take, and then I will take them. Thank you very much for your patient hearing.
Dr. Hari Kumar will take over the question and answer session. So everybody knows Dr. Hari Kumar, consultant endocrinologist at Magna, Hyderabad, and present secretary of Endocrine Society of India. Please take over, Dr. Hari.
Thank you, Dr. Santosh and Bipin sir. Good evening. As usual, excellent talk, how to present. Before I have 2-3 questions and then we'll keep it open for anybody. You didn't touch anything about the, say, debates in conference. Sir, a couple of sentences about how to handle debates during conference.
Okay. So as far as debates are concerned, if you are not comfortable, don't debate. Also remember that during debates, you are highlighting one aspect of an ambiguous issue, right? So you should be man or woman enough to admit that this is my point of view and I have been asked to speak on this. Somebody asked me to speak on self-led ureas in management of diabetes, I decline. Well, I don't choose them. So you should be, and you can choose topics, but you should highlight the aspects that are there. And at the end of the discussion, one must say that for the sake of discussion, we have said this metformin usage in let's say preventing cancer, which is very ambiguous. So you can't take a stand on it. But therefore, metformin being the drug of choice in managing heart failure. You can always say that there are some studies and we are trying to quote. So debates are very, very tricky. And most of the time they are for fun. And you should highlight that fact. And nothing is personal about it. And most people take it personally. So I feel that debate is clear about this. It doesn't mean that stand that you take there is sacrosanct, but you can highlight this aspect or that aspect. And most often I've seen that people at the end of the meeting say that, fine, this is how it is. I was asked to speak on this topic, the role of AMH in let's say, diagnosing pregnancy. So there might be some papers on that. So you can tell that, but I think debates are a bit tricky. So you should not take it personally. And at least the speaker who is the second person, you should tell him that I'm going to highlight this so that there is no, ill feeling at the end of that.
Okay. Second thing, as a speaker, how do you find or to deal with somebody either sleeping quietly on the front row or even snoring away to glory? Does that distract you?
I think you should be mature enough to ignore that person. Don't give value more than what he deserves. Or she also.
Okay. And generally somebody sticks to a particular viewpoint. You touched upon that, like in my practice, I did this and all that. But generally, if you, in a meeting, persisting with a question or a single question, how do you handle that? Somebody, is not ready to agree to another viewpoint.
Yeah, I think we can say that you are entitled to your perspective. Most evidence in this regard is not congruent with your thoughts. And I guess we have had enough discussion on this and we can meet, we can discuss this over tea, coffee. Anyway, I don't drink, so that means I will not answer.
Okay, thank you, sir. Any other anybody wants to interact with sir? Any question, anything which you faced awkward situation in a meeting or while presenting?
Some people, they continuously chat and they'll disturb you while you are speaking. So how do we deal with them politely or diplomatically?
It is, I think, diplomacy we have to learn from you. But in any case, what you can do, if this is somebody loud enough, so we can tell them politely that it appears that the talk is not interesting to you, and there might be some other people who are interested in it. So could you continue your chatting outside this hall, or if you're insisting, talk to the organization not to call me next time.
Okay.
And if somebody is asking the question again and again, we can tell them that please give chance to others also. Which is another way of saying that please sit down.
It's a pre-lunch talks, the audience are the most receptive and post-lunch are the most not attentive. How do you handle post-lunch talks, immediate after lunch?
place yours before lunch. No, I never do that.
We have no
But what I'm
option.
saying is, it's okay. So I think it depends on what is your content and what is your this thing. In some of the meetings, you find people are very prompt, and anyhow, those people are listening to you. That's enough. I never believe that if the hall is full, you should feel enthralled. If the hall is empty, people are disrespectful. No, not really. Maybe people are having some other interest, so we should respect their choices rather than saying that I went to that meeting all the way, I left my practice, and I went there, there only food. What is there? Whoever was there, you talk to them. So I don't think that you should worry about pre or post lunch sessions. In fact, sometimes you find that the organizers are also at pains to ensure people coming back to the halls in time. So this is organizers' problem. You are only an actor. The directors are the people who are organizing it. So don't take this very, very, very seriously. You are not delivering the talk. You are not deciding between Zelensky and Trump. You are just one of the speakers. They called you because they liked you. So it is not that something great is going to happen if your talk is missed by 20 people.
Okay, sir. Any other question or comments before we move to the jam session?
So how do you handle off-label questions? Like somebody, you're talking about something, but somebody starts talking like, the tirzepatide for PCOS management or something like that. If somebody starts talking off-label management.
I think some of the sponsors are very serious about the whole thing, but the matter of concern over there is that one should not be drawn into discussions which are not really having any scientific evidence on which the evidence has actually started. For example, some studies are published. There's a study published yesterday night, which you didn't have the chance to see. You can say that, well, I have not gone through that. If he says that, no, that trial on legacy was published yesterday, but there's one trial which is now published on the LPA loading, and everybody has not read it. So the says that no, there's one drug has come which LPA loading. So you can say that, well, I haven't read it and I think I need to look at it. But about that particular molecule, can I use tirzepatide to treat infertility? My patient showed dramatic results, and you can say that, well, I don't think that we have any published, to stay away from what is not published. For oral semaglutide, I think all of you know, till fold results were available, we used to say that the CV data is not yet available. Nothing wrong with it. So what is not available to you are a person who should be not losing credibility by saying that, it works wonders in PCOD. I have seen 4 women ovulate, one actually conceived. Then they'll ask you, sir, you have given a trial drug in a person who is becoming pregnant, you report it to the drug controller. Why all those problems? So I think you should, as if you are rightly, if I understood rightly, stick to the talk, stick to the indication for which the drug is approved. For example, oral semaglutide is not approved for obesity. If somebody says, if is it approved, you can say that it is not approved for usage. Mind you, any side effect of any drug, if it is seen for an approved indication, it's okay. Unapproved indication, you will be in suit.
Absolutely. Highlighting what is important, what is approved, what is published. That is absolutely important to give a clear-cut, unambiguous answer. Absolutely correct. If no more questions, I on behalf of
What's up? So it's very similar to something that we discussed a few days back. So like, for example, there is a insulin company who tells you to speak on premix insulin on one day. On the next day, they are asking you to speak on basal insulin. And you have alluded to it briefly, sir, on the talk. But what should be the disclaimer before you give such contrasting topics to the same audience?
I think what you can say, you can always say that prandial component needs to be addressed, and for initial part of an illness, the person who is predominant component is fasting hyperglycemia, this therapy is going to work. For others, you would require prandial component, which may be additional pre-meal boluses or a GLP-1 receptor agonist or a premix insulin. So you have said that in talk 1. when you go in the evening to talk on premixes, you will say that here is a patient who has high fasting, high postprandial sugar. He is not really committed. He is not monitoring, but we have to provide some kind of postprandial control. He stays, he is a retired person, his meals are on time, his quantity is on time, everything is on time, and he is comfortable with just taking 2 injections. So some control is better than no control. Therefore, in this situation, we are going to use this. Nothing wrong. We have not said anything that is wrong. And in fact, you can always say that, in fact, most of us are using either co-formulations of premixes, except in type 1 diabetes, where we strongly say, no, we have to use basal bolus only. Whatever may happen, we write letters to teachers, schools, and whatever, that they have to take afternoon injections. So when it is like this, then everything is okay. But in the morning, you say, no, this particular insulin is the best, and this is the only way it should be done. In the evening, the audience will also ask you. Some people actually ask you, it's the morning you said like this, then the morning was that session, evening was this session. But you look at the way in which the companies have also shifted. As long as there was premixes with one particular company, they used to hate basal insulin. The moment they had a basal insulin approach is the best. And I don't know how many of you are the focus was only on co-formulation. Insulin maybe once a week or whatever, or you can give basal plus, or you can give premix. So this is one of the approaches. Don't say that this is the only approach, because it is not the only approach. So I guess this is important. And sometimes you would have seen that there was a study called time in range or something, wherein there was a non-significant difference between one insulin A and insulin B. And one particular company was showing it as that this is important. There's I think how much 20 minutes difference or numerically different. The study was not done with that purpose. So why should you then say that this is there? Even for example, Pioneer 6. Pioneer 6 was done as a non-inferiority trial. And that along with the semaglutide trial, Sustain 6, was presented to the FDA saying that oral semaglutide and injectable semaglutide produce a meta-analysis benefit for CV outcome. FDA threw away those papers. They said, you do another trial with oral, then we will believe. So I guess we should be completely clear what we are doing. And I think all of you should listen to Dr. Ravi Mehrotra. Each slide, I don't know how that man, he studies each slide. And then he says, I went through this and this is good. We should do it. But many times what happens in a hurry, we accept some slides and then we find that what is this? What is this? You should know what the slides are, and if there is a doubt, you can always ask people.
Thank you, sir, for the excellent presentation about how to present crisp, concise, to the point, and unambiguous. As usual, as your presentation like this also. Thank you for taking your time out, and I hand over back to Dr. Lakshmi.
Thank you, sir. Thank you, Harikumar sir and Bipin Sethi sir, for that very eye-opening talk. So I learned a lot of do's and don'ts from this talk. So thank you for that. So moving on for the last session of the day. So this is a very fun jam session. This is the first time that we are trying this out. I hope you will all enjoy it, and I'm sure the participants will also enjoy it. So the moderator for this session is Dr. Anantraman sir from Magna Centers Bangalore, and over to you, sir.
Hi all, myself Anantraman. So I have done my MD from JIPMER Puducherry and DM from PGH Chandigarh. I'm a batchmate of Santosh. So I'll start with introduction. So we have eminent judge Dr. Amiya Joshi. He's MD Internal Medicine from Grant Medical College and DM from TN Medical College, Mumbai, Nagar Hospital. So he will explain the rules of the game, and then he'll assign the first topic actually. So basically, he'll tell the rules of the game also. Over to Amiya.
Please unmute yourself.
Please unmute yourself.
Am I audible now?
Yes. Yeah.
Thanks, Dr. Anantharaman and Team Magna for this opportunity. As we know, this is just a minute session and we'll be running it very fast. We have two teams. So in one team is Dr. Ejaz, Dr. Khushbu and Dr. Nikita. And in another team is Dr. Nishita, Dr. Parth and Dr. Varun. So we had a discussion about how to conduct it impartially, and we decided that let us have in toto some situations ready, and you will be told that, and then you will be asked to say in 1 minute about what exactly you will be doing. And it's not like I already knew this, you have to express that properly. And then we may have some comments from me and Dr. Anantharaman, Dr. Santosh, Dr. Lakshmi, and then we'll decide on who is the winner. I always feel that it's a learning experience, so everybody wins and learns, and maybe
So that's why we have two teams. There will be gold or silver.
Yeah.
So we'll give a combined prize.
Don't worry, Dr. Lakshmi.
There are no losers.
Get some Lakshmi. I hope I also get some. So सबको थोड़ा लक्ष्मी मिलना चाहिए. So I think I have divided into 3 parts and I have kept 9 situations ready. So one is science round, another is situation round, and third is profession round. So let us begin with the science round, and let me call upon Dr. Ejaz. Dr. Ejaz, are you there?
Yes, sir. Yes, sir. I'm there, sir. I'm here,
Just
sir.
introduce yourself and one adjective for you starting from A.
Sorry, sir.
You introduce yourself in a line and also give one adjective to yourself starting from A. So each one of you will introduce yourself and also give one adjective beginning from your the letter that starts your name. So if I am Ameya, I can say amazing Ameya, and I am consultant endocrinologist from Mumbai. So you can start with a similar introduce yourself, and then I'll give you your task.
Sir, I am Dr. Ejaz, adorable Dr. Ejaz, as an endocrinologist from Srinagar, sir. I'm currently working in Sikkim, Srinagar, sir.
Yeah, Dr. Santosh, how do we keep the timing? Anyway, how to keep it?
I'll keep the time.
Yeah. So your time, I'm just telling you your topic. Are you ready?
I'll keep the time. I'll tell time's up.
Yeah. So are you ready, Dr. Ejaz?
Yes, sir. Yes, sir.
So you have to tell me the inhaled medications used in endocrinology in a minute.
So one is insulin, which has recently been approved by Ecodex, sir. That has recently been approved by FDA, sir, for treatment diabetes. Sir,
So inhaled as many as yeah.
One is Ecodex, sir. We can also give sir Senacalcet, sir. We can calcitonin. We can give sir inhaler. Calcitonin, yeah, we can give inhaler. One second is sir Ecodex. We can give inhaler, and third is sir we can give. The only 2 I know, sir. I have only 2 drugs, sir.
So time.
You can speak anything about that. It's not a quiz, no. It's not like correct and wrong answer.
Yeah.
You can speak anything.
Yeah.
I think some problem with my. It's not a Viva, okay? You have still another 30 seconds. You can speak whatever you want
of Google. So maybe we are 10 seconds more.
The mineral can also be given, sir. Mineral, sir.
Yeah. Chalo. Thank you. Thank you, Dr. Ejaz. I think your time is up, and thank you. So we move on to our next contestant. Can you please introduce yourself and I give you your task?
Hello, sir. I am Dr. Nishchita. Nice Nishchita. I'm consultant endocrinologist in Chennai Vision Hospital in Bangalore, sir.
So are you ready?
Yes, sir.
Your question is topical medications that are used in endocrinology practice.
Starting in 5 seconds. Please think about it, then start.
Okay.
Yeah, start it.
So one is the transdermal patch of estrogen, uh, then testosterone transdermal that we use.
Mhm. So any medications you are using in a topical way in endocrine?
Okay, so in genital mycosis, we use candid clotrimazole.
You still have 20 odd seconds.
You don't need to make a list, Nishita. I think you can talk about the testosterone, how it is used also.
Is it a number of things? Or?
No.
Okay, testosterone gel, we usually tell use it in between the shoulders,
Here
the upper back.
is over. So thank you for the effort, though, and I think that was a nice beginning. I think then we go to the second round, and that's the situation round. So next contestant, please.
Next,
Or maybe
next contestant is Khushbu Agarwal.
Hello, sir. So
yeah.
I'm kind Khushbu Agarwal. I have done my DM from CMC Vellore, and I'm working as assistant prof in the same department as of now.
Yeah. So, Dr. Khushbu, just to maintain some uniformity in the next two questions, choose any number between 1 to 7, and I'll give you the task. A parallel task will be given to your other team contestants.
6.
So, okay, just check me what is there at 6. Okay. So you have started your practice as a consultant from CMC Vellore. You are a scholar, and suddenly you realize that you don't have patients, and there are a lot of other people who have a lot of patients. So how will you cope up with this, or how will you build your practice? Your time starts in 5 seconds.
So the answer is actually something that my senior once told me, that everybody starts at 0 no matter how big they are. Okay, so one thing that they have always told me is that you should always sit in one place and make sure that you're available to the patients. And I have the luxury that because I'm working in an institute as of now, so patients do come to me because of the name of the institute. But you have to be responsive to them, you have to be kind to them, and you have to listen to what they actually want. And you have to make sure and people notice. And we, like, even before endocrinology, we were medicine specialists. We have seen that they come with chronic problems. There are a lot of social problems associated with it. And if we try to address that problem, and we don't try to place the blame of a poor glycemic control, for example, on the patient, and try to work around a situation that eases their life a little bit, I guarantee you the patient will come back to us no matter how junior we are. That is one thing. Secondly, a lot of my seniors, like a lot of my batchmates, have now started advertising and doing videos and also. I mean, that's the second thing.
Thank you.
I think we are over time.
Wonderful minute. And now your other contestant is Dr. Parth. Dr. Parth?
Yes, good evening, everyone. So myself, passionate Parth, and that was wonderful, Khushbu. So hopefully I get something good sort of to talk on. That was a good scenario, which sort of I would have wanted to talk on because I've started my private practice. So I mean that was wonderful to hear.
So, Dr. Parth, now that you have started a private practice, your local IMA has approached you that do something to increase, basically do something for betterment of diabetes care, and that is for the diabetes day. So how do you want to plan it?
Right. So the first thing is I'll tell them that thank you so much for coming to me with this opportunity, because I'm really happy that, for Diabetes Day, you all are this aware for me to sort of put work into it. So the couple of things that I would look at is the void which is there. So quota, when I specifically in terms of my city where we are at, so there are a couple of just two endocrinologists as of now. So I would suggest ideas which would not only educate people about diabetes, but I would also want to do is include it, sort of make it a wholesome thing, which also looks at overall health, not just diabetes. So very recently, you would have seen a prime minister speaking on obesity, right? So although it's World Diabetes Day, I would want to structure it around not just diabetes, but maybe say, for example, obesity as well, wherein you are essentially looking at the crux of the problem, not just diabetes per se. And this primarily, I'm talking about type 2 diabetes, right? So we have a lot of younger diabetics at 30s and 40s who are coming with type 2 diabetes and obesity. So what I'll tell them is, one thing, we firstly put out, we do a press conference wherein we put out, data about obesity and diabetes, and we give them a solution. Second thing would be a
Over
camp
time.
that I would suggest, which I've already done. So we can do a medical camp as well.
1 minute.
Yeah, 1 minute is done. But thank you. Thank you. I think at least you thought over the situation, and both of you did well. So I think we move on to the last situation, and I would invite Dr. Nikita.
Dr. Ameya.
Yeah.
Give Dr. Ajaz and Dr. Nishita another chance because they were caught totally off guard actually. I think we should give them another chance on some other topic. Maybe they were caught totally off guard and they didn't know.
So I think we have some reserved topics, and I'll catch them on the guard again. So should we give them a chance now, or should we give them in the end after the third round is over?
The end.
Yeah, Dr. Santosh, how do we go? So we go to Dr. Nikita and Dr. Varun now, and then come back to Ajaz and Nishita, or how?
We'll come back to them last. Ajaz and Nishita.
Fair enough. Okay. So Dr. Nikita.
So I'm Dr. Nikita Godse. Nice, Nikita. I've done my MD from GS Medical College, Mumbai, and DNB Endocrinology from Kuklavin Hospital, Mumbai.
Yeah. So
and currently I'm practicing at my clinic, Sun Clinic, and Karuna Hospital.
Yeah. Welcome, Dr. Nikita. And I would request you to choose a number between 1 to 5. So that helps me give you the task next.
4.
Yeah, just let me check. So it is a situation where you have just entered the hospital. There are 20-25 people who have already done the booking, and they are all together in front of the OPD, a little chaotic, and you have just reached. So in next 1 minute, what all things you will do? Your time starts now.
So first, it is very nice situation to have so many patients waiting for you because I've just started my practice. But what I will do is I'll just tell the receptionist to send as per the appointment and just start seeing majority of the patient. And if someone has some other issues, like someone is elderly, unable to sit, or some other diseases, then I'll take them first, even though their appointment is quite behind. So that is how I'll accommodate elderly patient first, and children's who want to go to school or some other place, I'll accommodate first, and then I'll take the routine patients later. That's it.
Yeah, that was a good attempt. So you still have 5 seconds. 3, 2, 1, and we are done. Thank you. We'll come back to it. Dr. Varun.
Hi all. Good evening all. I'm Dr. Varun, versatile Varun. I did my DM from Jipmer. Currently working with Magna and Apollo in Bangalore.
Yeah. Hello, Varun. So the situation for you is that you are sitting in your OPD. One of your follow-up patient has came, and suddenly you have realized that she has started behaving in an abusive manner. So your 1 minute starts now.
So yeah, it will be surprising, like a patient like who is coming for multiple visits, like suddenly abuses. First, we'll obviously try to calm down the patient, understand like what's the issue. And if the patient is in front of us, I will like to understand what's the issue, then whether it is from the treatment point of view, or because of waiting issue, or it's because of some side effect of the medication, or it can be because of poor reception also. And some of the times, like if they're sending the glucose values and there was no response from the team, so that can be issue. I would like to first understand what has been happening, why she's little abusive, and also in case in the situations that if there is no reason, I would also like to see what has triggered their emotions and if required psychiatry referral.
Thank you. So your 1 minute is done, and thank you for that. So we have now a last round, comeback round for Aijaz and Nishita. It won't come for free. You will have to say one more adjective for yourself, and yeah, Aijaz.
Yes, sir.
Are you ready?
Yes. Yes, I am ready.
Yeah. So it has so happened that there is a person with gender identity disorder whom you were seeing, and that person has went to police station to report that that person has been abused, and then the police calls you as for an inquiry. So what are the things that you will be keeping in mind or preparing? Your time starts now.
Sir, first of all, sir, if a police calls me for any recording about it, first of all, I will inquire about the patient, sir. What is the name of the patient? What is the residence of the patient? Has the patient been has patient been has he consulted me any time in the past or not, sir? After that, when I read all the records, then I will see that what was the reason for his abusement, why he was abused, and second and other things I will see whether he has undergone any medication, he has taken any medication, or whether he has undergone any formal psychiatric assessment or not, whether he has undergone any any surgery he has undergone, or any medication he has taken. Then I will inquire about these things. Then I will try.
Is done. So, but fair attempt. Yeah. Good. And now we are back to Dr. Nishita. So yeah, Dr. Nishita, are you there?
Yes, sir.
Yeah. So you have got a very bad Google review given by one of your patient, and you just read it, and just the do's and don'ts you will keep in mind in next 1 minute. Your time starts now.
So I think this is something all of us dread when we at the present digital era of practice. I feel it's always very important to maintain patient records for this reason. If the person has actually visited you, or if it is somebody intentionally trying to sabotage. If in fact it is a patient who has visited you, there is always some reason for the review. In general, if the person itself is negative and miserable, they'll have number of negative Google reviews in their profile. It's visible. They'll have given minimal stars for many people, so you can just assess why the anger was, or in case it was actually a genuine mistake, we can always own up to it and say, this is what we went wrong in. And if sometimes it is just the technical things or the waiting issue or the reception issue, most complaints are about. So if we can correct it, definitely we should welcome it. And if it is something related to treatment, then probably we should introspect, because all of us learn with our practice. Each patient is a teacher.
Yeah.
So
Done for a minute. So I think thank you all of you. Do we have some time to discuss and give some comments, or we go to the
I think we'll take another 3-4 minutes and then close the session. So you can introspect, Dr. Amya.
Yeah, and I think you all are also fine to chip in, but just in a minute I'll put it on all. So in inhaled and topical medications, I actually expected that you will come up with little more options. Corticosteroid is one thing that we give both inhaled and topical. Then topical painkillers we use. There are, gonadotropins that can be given inhaled. But both of you did a good job. Now, coming to the second part, when I resigned as assistant professor at Nair and started my practice, my mentors told me two things. That whichever patient comes to you, say thank you to that patient, because you always come with an aura that I'm so and so. But then when you say thank you to the patient, most of your patients will come back to you. And the second thing was that I always had a habit of giving next appointment, which I learned when I did my ultrasound thyroid training at Tata Memorial. So patients still appreciate that fact that I used to give them appointment. Now I have stopped giving appointment because they are running 6-8 weeks full. But maybe it will help some of you. In a too crowded and nuisance OPD, when you are seeing, also the thoughts put forward were very good by Dr. Nikita. But I'll always suggest that when such a thing happens, rather than humanitarian, first learn to save yourself. Get 2-3 staff around, get couple of ward boys around. Maybe there is a code that you can just ring. But when people see that doctor के साथ में और 3-4 लोग हैं, they automatically mellow down, follow the discipline. Don't try to overrun. But yeah, that your approach was really nice. You thought of good in that 1 minute. And then we come to the abusive patient. Why I asked this question was that when I had a patient, when she came and just started shouting at me in the Nair OPD, my professor said just check her sugars, and her sugar level was 35 that time. So just remember that abuse can also be endocrine problem, hyperthyroidism, some sort of issues which can be triggering. So your attempt was also nice, but you handled it very, very well. For Dr. Parth, I have to say that when IM had asked me, I said it's hopeless to give a lecture and do some free camps. Make everyone exercise, have a marathon and a cyclothon. Let everyone do it. So that was just my approach. But yeah, your thoughts were also very, very nice. And for the Google review for Dr. Nishita, I will say that when I had this situation, I just decided the first thing is that it should not be affecting what you are doing in your day-to-day life. You can respond it in your own way. You can be anhedonic. You can just move on. But it only means that you have enough patience. And I always say that after the first negative review I got, my OPD just spiked because people came more prepared. They were okay to expect little disappointment. And the last was that whenever you are called by police, the police always gives you all these details that your patient so and so you are supposed to come. What you need to remember is that firstly you should be thorough with your notes. Always check if some other consultant has seen, so that you are absolved. So when I was called in such a situation, another endocrinologist had also seen, and I told them that, sir, one more endocrinologist has seen. The police was actually keen to know that can the person's condition make such a way that the person will himself approach in a provocative manner for an abuse and all that kind of things. You just have to stick to science. You're always compassionate to your patient in the clinic, but here you are an expert doctor. Try to be very, very scientific, and they will also have the same approach from you. So these were just my 2 cents to add on. I will invite Dr. Anantharaman, Dr. Santosh, Dr. Lakshmi to come up with their comments till I do some little calculations. Maybe 2-3 minutes you just have to fill in.
Sure. So thank you so much. I really enjoyed this round, and thanks to all the participants, for coming on board. So I have to tell you that I had asked at least 20 more people, and none of them agreed, and all of you came on board, and it was very brave and sportive of you. None of you knew the questions, so I mean, that's very nice. So thank you. I don't think I would have come up with such spontaneous and fun answers. And thank you to Dr. Varun also, who stepped in just now. We just called him now and he just stepped in. So thank you all. I had fun. I hope you guys had fun too. So this is something that, we were trying out for the first time. And we would be happy for any, feedback from you or comments from you as well.
So I was just messaging Ameya saying, awesome, Ameya should be the adjective for Ameya after hosting
Correct.
this session so
Fabulous.
very well.
Seriously.
Fabulous.
Seriously. Thank you, sir.
Yeah, so I think मन तो ये कर रहा है कि since they all have agreed, if it is okay for Team Magna, give prizes to all of them. Do we really need to declare winner?
So
I think we will close here if that's okay. And if you really insist, we can have first or second, but I don't think it is because it, as Dr. Lakshmi said, I could see her effort. And since all of them have participated and all did actually very well. So even if I give some result or Dr. Anant Raman gives some result, there will always be up and down. So if I think Magna has a lot of Lakshmi, they can just be little liberal. And what do you say, Dr. Santosh, the final boss?
I will concur with what you say.
Yeah, so I think we agree. Let us give all of them a token of appreciation. Maybe participants want to say something.
Just one word on the Google review. So we were at IIM Ahmedabad for one of these things, and they were sort of teaching us the management part. And therein, we had a specific sort of person who would discuss and guide us as to how to approach these things. So what I learned from that was that one thing is, no one is going to see that you have a negative review if you have a lot of reviews. So what they see is how you respond to that review. So firstly, don't take it personally and keep a professional response to that review, because if you are going to get personal and respond in a way that the person has responded, then it puts you down. So I mean, their general sort of suggestion was, which I sort of agreed on to, was that you keep your dignity. Of course, like ma'am suggested, that you first see if it's a genuine review or not. Maintaining it's a genuine review, then you sort of maintain your dignity and give a professional, dignified response and end it there, and don't take it personally. That because because the people are not going to see just that one review, they are going to see your response to all of those reviews. So that was one thing that I felt was useful.
That's very correct, actually. We do that in Bangalore. So what happens is that our manager's number is left in the response to the review, actually. So most often the calls come to the manager's number. That number is not there anywhere else, actually. So, so we know that, people read the response to the reviews, actually. So, and then they call the particular number. So if you have any this thing or, any further queries, you can call this number, that we leave a number specifically. So, and people read the reviews, actually, and reviews are pretty important. And as long as we handle the response to the review very diplomatically, nicely worded reply, it should not cause any trouble. In fact, the negative reviews responses, at least in a month, we get 1 or 2 patients. You want to add some closing words for the program, Dr. Anantraman? I mean, I would say that, if everybody's name started with A, everybody would be awesome. So it was good. It was good fun. So it was good to meet you all. I mean, we don't get to meet in person too often nowadays, actually. So because we are all busy doing so many different things. So I hope and I wish that we have more of these meetings. So
it was
thanks. Yeah. Thanks to Lakshmi and Santosh for putting this together at short notice, actually. So thanks to
the participants also. I think you all did well.
Participants also. They took out time and they participated.
Yes.
Thank you, sir.
Thank you.
All of you who are in this program.
Thank you, sir.
I believe that at one moment there were six endocrinologists who were logged in and they were listening to all of us. Getting 66 endocrinologists even in Esiko was difficult, actually. So we got them all together in one place, and it was great fun. I think I especially enjoyed it a lot. I'm sure everybody has. So good night and thanks a lot for participating. Thank you.
Thank you.